social media liaison for Dermatology Talks, and it is my pleasure to introduce to you Dr. John Barbieri. He is an assistant professor at Harvard Medical School and the director of the Advanced Acne Therapeutics Clinic at the Brigham and Women's Hospital. He is an associate editor at JAMA Dermatology, and he is also the co-chair of the American Academy of Dermatology Acne Guidelines Work Group. His research focuses on conducting innovative clinical trials and epidemiology studies to identify the best approaches to care for patients with acne. He also focuses on exploring the role of patient-reported outcomes to ensure that we are capturing the patient's voice and perspective on their care. So without further ado, Dr. John Barbieri.
Thanks, Kelly, for that kind introduction. It's a pleasure to be here today to talk about taking care of patients with acne, and looking forward to the next hour together. In terms of disclosures, I do have funding from NIAMS to study a comparative effectiveness trial of spironolactone against doxycycline, and we will be discussing off-label treatments for acne during this talk. As kind of a roadmap of what we hope to cover today, we'll start by discussing how we can reduce antibiotic use in dermatology. We'll talk about the epidemiology and the role for hormonal therapy and isotretinoin, and we'll shift gears into discussing ways that we can improve outcomes for our patients that we do end up treating with isotretinoin. So let's start with the epidemiology of antibiotic use in dermatology and in acne. So believe it or not, dermatologists, we are number one. We are the number one prescriber of antibiotics per doctor of any specialty when the CDC looked at this a couple of years ago. And even if you go, hey, we're on an absolute level, we're not as high as some of these groups in terms of number of prescriptions, it's important to keep in mind that many of our prescriptions aren't just a 7-day course of antibiotics for, pneumonia. They're a months-long course of antibiotics for treating non-inflammatory or inflammatory non-infectious conditions. And among this antibiotic use, 60% of it is for acne. So much of our antibiotic use is for acne. Again, we're the number one prescriber of it, and we're using most of this not for infections. We're not struggling, is this patient a viral URI or pneumonia? These are patients who have non-infectious conditions that we can treat with non-antibiotic therapies. And as I kind of alluded to, these courses are often for prolonged duration. So this is some data looking at United States prescribing on dermatologists and non-dermatologists. You can see that the mean duration of therapy is many months. About 30% of patients are treated for more than 6 months, and many of them actually aren't on even concomitant topical therapy, like a topical retinoid or benzoyl peroxide. Internationally, we've looked at this in the UK, even similar types of results, and among PCPs even worse, with 60% not on any concomitant topical therapy. And this antibiotic use is important. We often think about antibiotic resistance as the issue that we're concerned about, but there are many other antibiotic-associated complications. Patients who are treated with antibiotics are at higher risk of breast and colon cancer. Patients treated with antibiotics for acne and other conditions are at higher risk potentially of inflammatory bowel disease. In fact, this is probably why isotretinoin was initially considered to be a medicine that put patients at risk of inflammatory bowel disease, was they got antibiotics and they got isotretinoin, and it may have been the confounding from the oral antibiotic use that led to those initial reports. And when people have controlled for that, they really haven't found any associations. And then finally, oral antibiotic use for acne is associated with increased risk of strep throat, of pharyngitis. And then beyond these complications, we have to think about the microbiome too. And this is something that we're beginning to learn more and more about. So this is a study looking at patients treated with antibiotics. This is just the skin microbiome. It's not the gut microbiome. These are patients who got minocycline for 4 weeks, and they looked at their microbiome before they started, at week 4 at the end of that course, and then at week 5 and week 12 to see what happened 8 weeks after they stopped. And what you can see is that gram-negative abundance rapidly increases when these patients are treated with minocycline. And maybe that explains the development of gram-negative folliculitis with oral antibiotic therapy and acne. We can see that streptococcal species increase, and even after the antibiotic is stopped, these still remain elevated compared to baseline. And this may go along with our risk of oropharyngitis that we were discussing earlier. And importantly, patients, we talked about acne is a non-infectious condition. Bacteria certainly play a role in it, but you don't need an antibiotic to treat it. And our patients, they want non-antibiotic alternatives. That's what they're looking for. In this survey by Jim Rosso, which had about 600 patients and their family members treated with acne, about 50% have been treated with an antibiotic. Yet 75%, 3/4, would prefer a non-antibiotic treatment for acne if that were available and worked just as well. And although I suspect many were counseled about other options, in the survey at least, only 30% we're aware of these non-antibiotic options. So this again highlights this need, this opportunity. We're prescribing tremendous quantities of antibiotic to treat non-infectious conditions like acne. We can be better stewards for our community. We can prevent antibiotic-associated complications. And this is what our patients are looking for. So how can we do this? Well, often people say, let's use quote unquote submicrobial dosing. Let's use low dose antibiotics. Is that our solution? Let's go into some of the basic arguments and assumptions in this idea. So first, it's that these submicrobial doses are below the minimum inhibitory concentration for bacteria, and that when you're below that MIC, that minimum inhibitory concentration, you're not going to develop resistance or disrupt the microbiome. And is this actually what we see? Well, this is the classic graph that gets used in my experience to describe that these concentrations are below the MIC. As you can see, and if you read this paper, they actually don't say what this is. We'll go into this a little later, but minimum inhibitory concentrations of antibiotic are species specific. It's going to be different for staph and strep and gram-negative enterobes and actinobacter. It's going to be different for each species. So what is this? It may be for some bacteria that's below the MIC, but it might not be for others. And importantly, what about other compartments like the gut? Before you absorb the antibiotic, it might be at a much higher concentration when just in that small area dissolving from the pill before it gets spread out over your entire body. And as we talked about earlier, we know that oral antibiotics are associated with an increased risk for inflammatory bowel disease and colon cancer. And then the second part of this is, are these concentrations below the MIC okay? I mean, if you just thought about how would you make resistance, you give bacteria just enough that they see it, that they need to respond to it, but you don't kill them. So that idea of dosing below the MIC actually might be exactly how you create resistance. This was what Alexander Fleming feared when penicillin was discovered, that this would be done. And when you look at in vitro data, it actually suggests that it might be even worse, that when you use low dose antibiotics, it might increase mutagenesis and lead to faster development of resistance. And then when we look in the actual, like, what about the clinical data? I'm not sure they really support the conclusion. So this is a study that says there's no changes in antimicrobial susceptibility. Look at this. The yellow 20 milligrams once daily, the white 20 milligrams twice daily. This is often, I think, what people consider to be a quote unquote submicrobial dose. Look at the changes in resistance of these actinobacter from almost nothing up to 30 micrograms or per milliliter. Huge change. Fortunately, it does seem to go away over time, but certainly something is happening here, even at these low doses. And this is some other data from another study looking at staph and strep resistance. And you can see that even in this doxycycline 20 milligram group, they're developing resistant staph and strep. That's what these red boxes are. So even at low doses, this can happen. And then, well, what about sarecycline, narrow spectrum antibiotic? We've solved it, right? We have a narrow spectrum one that's FDA approved for acne, no more problems. Well, certainly it looks better. I mean, you look at the gram-negative enterobe data, it's about 32-fold higher MICs. Again, is that going to be relevant in the gut where the concentrations might be higher? I don't know. There's no real microbiome data, but we think that's probably better. But look at these skin ones. They're really only 2 to 4 difference. In fact, sarecycline's been proposed as a treatment for MRSA. So certainly it still has impact on other bacteria. Maybe less for some, it's certainly an improvement, but it's not necessarily a solution where we don't have to worry about this issue anymore. So to summarize the epidemiology, we use a lot of antibiotics in dermatology, with much of this used for acne, again, a non-infectious condition. While antibiotics are a very valuable treatment option for many of our patients, there certainly are harms, both with respect to resistance in patients in the community and antibiotic-associated complications, and our patients are looking for alternatives. They want us to give them non-antibiotic treatments. And fortunately, as we're going to go into, we have options. We have hormonal therapy, we have isotretinoin, and there may be opportunities to optimize how we use these for our patients. And lastly, rather than focusing on limiting duration, which is often what guidelines and organizations say, these are arbitrary, right? I showed you microbiome changes in less than a month. Where does 3 months, where is like 2.9 months, that's good, 3.1 months, that's bad? Where does that come from? It's just made up. And similarly, low-dose antibiotics, not evidence-based approach to solving this problem. We should focus on limiting the number of patients we treat, about thinking about who doesn't need an antibiotic, who can we treat with a non-antibiotic treatment that they might actually want and prefer. So let's move on to hormonal therapy as one of our options to do this. So this is an interesting study from Ariel Nagler's group at NYU. They looked at 4,000 patients that were treated for acne. It's an observational study. And the first thing they found was that those who were treated with an anti-androgen, a combined oral contraceptive, or spironolactone, they received nearly 3 months fewer antibiotic days of treatment than those who didn't. And one thing I point out here, look at just how many days of antibiotics these patients are getting. The average patient in this group is getting 300 days of antibiotics who gets treated with it. So, forget about 3 months, these patients are getting treated for nearly a year. But you can see that when those patients get anti-androgen therapy, they are less likely to be on long courses of antibiotics. But it's usually not the first thing you pick. This is why they're getting those 225 days. If you look at patients' changes in treatments over time, the most common first treatment, not surprising, systemic antibiotics. When you study this, systemic antibiotics are prescribed about 3 to 7 times more often than hormonal treatments for women with acne. But you can see over time, where do patients end up? Wow, they're ending up on hormonal anti-androgen treatment. They're on combined oral contraceptives, they're on spironolactone. They're ending up on those treatments over time. So that brings into this question of, if patients are ending up here, should we be starting there? How well do these treatments work? And how do they compare to oral antibiotics, our other most common first-line option for moderate to severe acne? Well, several combined oral contraceptives are approved for acne, so we know they certainly can work. And compared to oral antibiotics, this is maybe not the best way to do it, but it gets a little bit at it. So this is a study where they looked at trials that examined the efficacy of oral antibiotics, and they looked at trials looking at the efficacies of combined oral contraceptives. Ideally, you might do something like a network meta-analysis. They did kind of like a version of that without quite as much statistical analysis. What they found was at 6 months, the rate of reduction of inflammatory papules and pustules very similar between oral antibiotics and combined oral contraceptives. You can see, as we'll talk about later, hormonal therapy is slower. If someone wants to be better next week for their prom, hormonal therapy is probably not the right way to go. But in the long run, and many patients, especially adult women with acne, are going to have acne that's going to take years to get better. Those patients do very well with these hormonal treatments. And this is just a combined oral contraceptive pill. Now, when I talk to dermatologists, a lot of them don't feel comfortable prescribing them. So I want to talk a little bit about how we do that. So there's 2 main ways to start it. The quick start way is really just begin it on the day of the prescription, as long as pregnancy has been excluded. And then the Sunday start one would be to start it on the first Sunday after the period, making sure to have some form of backup contraception during that period and with the first week of use. And now actually there's no pap smears or pelvic exams that are mandatory prior to starting. So certainly you might want patients to be getting their routine gynecologic care, but there's no reason that as a dermatologist, you can't think about starting a combined oral contraceptive as a treatment for acne. Now, what are the risks of combined oral contraceptives? The main ones really are venous thromboembolism, stroke, myocardial infarction, and then potentially you have to think about ER-positive malignancies in certain patients. So venous thromboembolism, that's the main one, DVT and PE. Let's conceptualize this. So if we just look at someone in the general population, their risk of getting a DVT in a reproductive age woman is about 3 per 10,000. That person starts taking a combined oral contraceptive, actually doubles. But on an absolute level, it goes up by 3 per 10,000. You'd have to treat 3,000 people with a combined oral contraceptive to have one more patient have a venous thromboembolism. And potentially with drospirenone, a little bit higher, depending on the study, 6 to 9. So that's like Yaz, Yasmin, Nikki, in terms of some common brands. And then pregnancy, 30, so substantially higher. So being pregnant is a much higher risk of ETA than being on any of these combined oral contraceptives. And then we talked about estrogen receptor positive malignancies. There's some conflicting data, but likely there are higher risk of breast cancer among patients who are treated with combined oral contraceptives. Again, attributable risk, very small. You have to treat like 10,000 people to have one more case of breast cancer associated with the combined oral contraceptive use. And notably, there's a much decreased risk of other kinds of cancer, like colon cancer, ovarian cancer. In fact, the overall cancer risk is lower among patients who are treated with combined oral contraceptives. So on net, I'd actually argue that this is probably a benefit for patients when it comes to the risk of malignancy. And then who shouldn't be prescribed combined oral contraceptives? What are kind of the main contraindications? The most important one that I think comes up in our practice is patients who have migraine with aura. So it's really important to be asking about that. Patients who are over 35 and smoking 15 cigarettes a day usually is not a huge problem in our population, but another important one. Of course, patients with risk factors for those complications we talked about, and then patients who might not be able to metabolize it well or already have a known history of an estrogen receptor positive cancer. But most of the patients that we're seeing for acne aren't going to fit into any of these contraindications. Usually not a problem. So moving on from combined oral contraceptives, what about spironolactone? So it's getting more and more popular among dermatologists. It's increased dramatically kind of in the early 2000s to 2010s. But like I mentioned, here's oral antibiotic use up here, here's spironolactone use down there. Huge gap when we look at women with acne. Spironolactone is far less frequently prescribed. and among non-dermatologists, even less so. So it's not used that frequently for acne compared to oral antibiotics. This is another way of looking at it, where we can see that oral antibiotics, they get used about, even in 2013, about 3 to 7 times more often for women with acne than oral antibiotics like doxycycline, minocycline, et cetera. And spironolactone can be really effective. This is a clinical trial of spironolactone monotherapy. And I'd say, this is a pretty good improvement for just doing one treatment and nothing else. Of course, in these, they always pick the best pictures, I bet, but still. And low doses can certainly work. This is a randomized controlled trial looking at placebo versus 25 or 50 milligrams. But you can see there's really a dose response curve happening. 50 milligrams works a lot better than 25 milligrams a day. And I would argue actually that even higher doses are probably the right starting point. We at the AD, I feel like always have a debate over should you start low and go up or start higher and come down. And I'm certainly in the higher and come down group. And part of the reason is this, is that when we look at patients who are treated over time, this is a retrospective review of 403 patients who were treated at PAN with spironolactone. Most patients end up on higher doses over time. They don't end up going down to lower doses over time. The patients who start at 25 to 75 almost always end up eventually getting to higher doses rather than going down. So the fact that most patients end up going up rather than down, and as we're going to talk about later, the fact that spironolactone and hormonal treatments are slow treatments, it takes a while to know if they're working. So I'd much rather start higher, and if patients have some lightheadedness or some irregular menstrual periods, we can come down on it, than have them spend 3 or 5 months on too low of a dose, come back and say, why am I not better? And we say, oh, we need to try a higher dose. That often is not a message that patients want to hear. This is more data, again, that higher doses may be a better starting point. So this is another randomized controlled trial, not a huge N, but you can see doses around 100 to 150 milligrams a day. That's where you start to see a plateau and improvement and do better than doses of 50 milligrams a day or less. So this is another study that I think supports that kind of 100 milligrams a day, maybe kind of a sweet spot dose that balances side effects and efficacy. And although we don't have randomized controlled trials yet, we do have a lot of observational data to support the use of spironolactone as being effective for women with acne. This is an earlier study, 84% of patients had good improvement. Here's our study where, again, about 80% of people had improvement or clearance on their face, chest, and back, respectively. I think this ISP-Jubert study is really interesting, where 60% of the patients had previously relapsed after treatment with isotretinoin, yet 71% had a good response to spironolactone. And again, these data, median response of 6 months, maximum response 3 to 5 months. Spironolactone is a slower medicine. It's not a medicine that people are going to be having a lot of improvement in 4 to 8 weeks. It takes some time and it takes some patience. Back to that question I raised earlier, how does it compare to oral antibiotics? We don't have a head-to-head trial, but this is kind of us trying to do the next best thing. This would be a new user active comparator cohort study. So we take people who haven't been treated with acne and they either get started on spironolactone or an oral tetracycline. We follow them forward over time and try to match them as best we can with things like age, other topical medication use, history of polycystic ovarian syndrome, things we think might impact their acne. And what we can see is that the likelihood of them being switched to a different treatment, suggesting that, hey, whatever this was didn't work, is very similar between those who are prescribed spironolactone and those prescribed tetracyclines. There's no significant difference in the likelihood of being prescribed a second treatment. So that suggests that these have similar effectiveness, and many patients, almost 90%, end up staying on this treatment, which suggests that it's working for them. And I mentioned we don't have any randomized controls yet, but we should have some soon. The SAPA trial, I think, has just finished in the UK, so I'm looking forward to seeing those results. There's a trial in France comparing spironolactone to doxycycline, and we have, as I mentioned at the beginning, an ongoing study right now across several sites in the United States. It's actively enrolling. And if you're interested in it, please feel free, if you have patients who are interested, or if you're interested in being a part of it, please feel free to reach out to me and we can talk more about it. What about side effects? For most patients, spironolactone is pretty well tolerated. The most common side effects are menstrual irregularities and breast tenderness. These are very dose dependent. On doses of 100 milligrams or less, they tend not to be that common compared to doses of 150 milligrams or more. They both can be improved by using a combined oral contraceptive at the same time. And then other important ones, even though a lot of studies describe the rate of diuresis is only about 5%, I think it's actually probably higher, but most patients just aren't particularly bothered by it. And then the one that I actually, in many ways, worry the most about is postural hypotension, of having orthostatic hypotension or lightheadedness, of fainting during activity, because that's obviously a way someone could get injured. So I actually will start it, even though I say my goal dose is 100 milligrams a day, I'll start at 50 milligrams a day for the first week just to try to identify people who are already starting to feel some of those symptoms and not go up. And I'll really tell them, like, when you start to be careful about this, make sure that you feel okay on this medicine before you start doing anything intense or vigorous. Be on it for a little bit of time first so that you don't get into that issue. A discussion over the years about spironolactone has been this potential risk of breast cancer. We recently did a systematic review and meta-analysis that really highlights there's no increased risk of breast cancer with spironolactone use, though there is a need for more studies among patients with acne. Most of these studies are used in older populations. Another thing, mostly I hear from pharmacists is, can spironolactone and drospirenone containing combined oral contraceptives be combined? And really all of the data we have suggests yes. In prospective studies, there's really no obvious increased risk. And in a large cohort study, there is no evidence of increased risk among patients who took them together as opposed to spironolactone alone. And the other way I just think about practically is that the potency of 3 milligrams of drospirenone is like 25 milligrams of spironolactone. And most of us, I don't think, would be that concerned going from like 75 to 100 or 100 to 125 milligrams of spironolactone. So combining these really, I wouldn't expect to be an issue just based on that alone. Lab monitoring, we get more and more data. There's now 3 or 4 studies on this, that in young, healthy women, there's low usefulness to lab monitoring on patients who are being treated with spironolactone. This is work from Ross Mostagimi's group, which shows that the likelihood of having abnormal tests, very uncommon, but importantly, it's just as common at baseline as on treatment. It's probably just background noise, and it doesn't lead to changes in management, right? If we're doing lab testing, it should help us avoid side effects or make decisions. And here it's not doing either. This is a study from Bethany Slasher's group that suggests maybe the risk might be higher in older women who are over 45 years of age. So this is a really small sample size, just 12 people. So we have to take that with a grain of salt, and we need more data. And there's actually some other studies that might contradict this a little bit. But I think in general, like, I don't think about like a cutoff. This is just like the antibiotic thing. It's not like you're 44, don't worry about it. You're 46, you should. I think of it more, if you have risk factors for hyperkalemia, if you're on medications like NSAIDs or other medications that might increase your risk, if you're an older person who might have, or you have worse renal function or other risk factors, those are all reasons to consider monitoring. When someone who's relatively young and healthy without other medical problems and no risk factors, it's something that we likely don't need to do and isn't helping our patients. Yeah, despite all of this, monitoring is really common. This is the Arash Mostagimi study that we did together. We're like, why did we do that first study? It seems like nobody's changed anything. So there's an opportunity here to provide more patient-centered care. The data really supports that there's a low usefulness to monitoring potassium among patients who are being treated with spironolactone, who are otherwise young and healthy. Yet in this population, 40 to 60% of people are getting their potassium checked regularly at baseline while on treatment. So an opportunity for improvement in both of these places. And then finally, with respect to hormonal therapy, we often hear like that there's this hormonal acne, that those are the only people who should get it. But when you actually look at adult women with acne, most of them have acne that looks most like adolescents. And we look at factors that predict PCOS, hirsutism on the chin or chest, having acanthosis nigricans and axilla, those are predictive. Mandibular acne actually is not in that study. So although certainly I think there are patients who have PCOS and have lower phase acne, that certainly is a phenotype, most adult women with acne don't. And really all acne is fundamentally about hormones. If you look at a curve of DHEA over your lifetime and a curve of acne over your lifetime, they basically mirror each other. So all acne is fundamentally about hormones, and keep an open mind when thinking about which patients might benefit from hormonal therapy. So to summarize this again, really all acne to me is hormonal. Any patient can benefit from this, right? Clascoterone works in men with acne, and spironolactone works in men with acne, and some of the trials were done that way. It just isn't something you routinely use because of the side effect issues of gynecomastia. I really think dermatologists should feel comfortable with combined oral contraceptives. They're a useful treatment for acne, and they help us when we're using other teratogenic medications like thalidomide if we're using that, and rarely for connective tissue disease, or if we're using isotretinoin, really common medicine, or other teratogens, acetretin, et cetera. Really, the main contraindications are going to be migraine or a history of thrombosis in the patients that we're treating, and it's not that hard to start. And then I really do think spironolactone is an underutilized treatment for acne. Of course, I have COI here because I'm studying it. I think 100 to 150 milligrams a day is often the optimal dose for most patients. We really are over monitoring potassium, and we should think about doing that less in our young, healthy patients. And our recent large meta-analysis really supports there's no meaningful risk of cancer, which is reassuring. And there's even some studies suggesting that in patients who have a history of breast cancer, spironolactone can be used safely. All right, let's shift gears and talk about isotretinoin. again, another alternative treatment to oral antibiotics for patients. And what we know about isotretinoin is patients often get about a year of antibiotics before they end up on this. I think if we had a crystal ball and we said, you're going to end up on Accutane, isotretinoin, most patients would say, let's just do it. Sometimes we have to kind of get ourselves in the right mindset to be ready for it. And sometimes we don't know who's going to need it. But I think often we wait a little bit too long to pull the trigger for patients who ultimately end up there anyway. So let's think about side effects and how we can manage those in our patients. So everybody really gets dry skin on this medication. Even at lower doses, like just 0.5 milligram per kilogram per day, 94% of people are getting dry lips, and many people are getting dry skin elsewhere. In fewer people, we also start to see some other issues in terms of mucocutaneous dryness. And I want to touch a little bit on eye problems because it's something I think doesn't get enough attention. So when we look at, there's a number of actually ophthalmologists who really study this well, where they look at patients who are treated with isotretinoin. They do all of these different kinds of fancy ophthalmology tests before they start treatment, while they're on therapy and afterwards. And what you can see is that there's a number of parameters that change on treatment. Patients have reduced tear production and quality. You get increased conjunctival staining, which may go along with that. You get decreased corneal thickness, which does improve over time. It might create some vision changes for patients while they're being treated. And we just look at this OSDI scores, which are a patient-reported outcome, kind of like dry eye. Patients get worse scores while they're on treatment. A lot of these changes, not surprisingly, you could think we talked about the sebaceous gland, right? And the face, that's how we're using it to treat acne. Well, the meibomian gland in the eye also can get impacted by isotretinoin and can lead to some of these issues with eye dryness. And you can see there's important changes that happen to them. I'm not going to try to go into what meibography looks like or all the different shapes they can see, but when the ophthalmologists look at patients' meibomian glands while they're being treated with isotretinoin, there are important changes to the morphology. Fortunately, a lot of these changes do improve. So tear film changes seem to get better and tear quality returns to baseline within 6 months of treatment completion. We look at just average patients. It doesn't mean that nobody's going to have lasting eye dryness, but in general, it seems like this improves after treatment. Corneal changes also seem to get better, so that's reassuring. But some of these changes do seem like they're more persistent. So when we look at meibomian gland changes, these might hang around a bit more for patients. Even a year after treatment with isotretinoin, they still have meaningful changes to their meibomian glands. This is another way of just looking at these specific metrics that ophthalmologists use to grade changes to meibomian gland. You can see that these changes, they certainly peak at the end of treatment and can improve, but they don't necessarily get back to baseline. And I think this is something we should really be thoughtful about when we're treating patients. Using lower dosages does seem to reduce these. So this is a study where patients who are treated over 0.5 milligram per kilogram per day have more changes than those treated by less. I think that parallels all the other mucocutaneous dryness symptoms that seem to have a dose-dependent effect. And there might be a role for omega-3s in helping with these. This is a little tricky to interpret because there's no omega-3 alone group. And at this study, they're looking at patients' changes to some of these metrics, and they randomize them to either just isotretinoin or nothing, these things called punctal plugs, where they're kind of blocking where your tears drain out to try and help keep the tears there, or punctal plugs and omega-3s. And you can see patients who are treated with isotretinoin alone, their OSDI scores, this is this measure of eye dryness, get up, that's bad. But if you give them punctal plugs or punctal plugs plus omega-3s, that doesn't happen as much. If you look at tear parameters, you can see they get worse with isotretinoin. But again, if you do these interventions, they don't. And interestingly, this is one where I wonder if omega-3s do something special on their own, is when we look at meibum quality, the meibomian glands, if we look at isotretinoin, again, changes, we discussed that before, punctal plugs not that different. That kind of makes sense, right? They're just keeping the tears in your eye. They're not actually helping any of the structures in there. But if you give omega-3s and punctal plugs, now we see this decrease in changes to the meibomian glands. And it's possible that the omega-3s may have a protective role for the meibomian glands that could help reduce dryness. And we know it can certainly help with other mucocutaneous dryness. These are some trials of omega-3s where there are lower rates of dry lips, nosebleeds, dry skin among those who are randomized to omega-3s compared to those treated with isotretinoin. These studies really aren't powered to look at eye dryness, because again, that's a less commonly reported symptom. But again, it may be something that can help there. And then during treatment, artificial tears are a helpful adjuvant thing that we can do. And here's just a couple. I don't have any loyalty to any of these. These are representative brands that I think some ophthalmologists think are relatively high quality. So that's some ways that we can deal with mucocutaneous dryness, thinking about using omega-3s in addition to some of the moisturization techniques that we tell patients can help really throughout with mucocutaneous dryness, but also being thoughtful about that it does seem like this medication can cause persistent dryness, particularly changes to the meibomian glands in the eyes, which makes sense. That's what we're trying to do in the skin. So it's something we want to be thoughtful about. And with this push toward longer and longer dosing to try and prevent relapse, we should be thoughtful about, are we actually putting patients at unnecessarily risk of chronic dryness when we do that? Another helpful adjuvant to think about is antihistamines. So a common problem we run into when you start isotretinoin, or really retinoids in general, is having that initial purging or flaring. And this is an interesting trial where they randomize patients to either just isotretinoin or isotretinoin and desloratadine, antihistamine. And you can see the rate of initial flaring, 33% in those with isotretinoin, just 5% in those who get that combination. So it seems to be able to help reduce flaring. This actually can make sense because they're believe it or not, histamine receptors on the sebaceous gland, so they can be impacted by antihistamines. The other thing that can help is make people get better faster and be more satisfied. Again, I think related to the potential role of histamine on the sebaceous gland. But here you can see non-inflammatory lesions improve faster, inflammatory lesions improve faster, their global assessment improves faster. Sebum secretion, again, maybe that's a sebaceous effect, improves faster, less redness, and patients are more satisfied, 50% in that combination group versus 20% in the isotretinoin group alone. So it's something we really should think about. It's a simple thing to do. I think especially when starting isotretinoin, it is a valuable thing to consider to help our patients get through that initial period. Coming back to dosing, a few things here. One is, do we need really high daily dosages? And when we look at this is a randomized controlled trial. They have 3 groups. There's this intermittent group, there's a lower group, and this is pretty low, 0.25 to 0.4, and then this normal group, which honestly is maybe lower than what a lot of us do, 0.5 to 0.7. And what you can see is that the group that gets the intermittent dosing, they do worse. They have slower improvement. They're going to relapse more, as we'll see. But the groups that have that kind of low versus medium dosing, very similar in terms of how quickly they improve. Very similar in terms of relapse rate. Here are those 2 groups with that low and medium dosing. Here's that group with intermittent dosing that does poorly. And the satisfaction is higher in the low growth group. So, again, similar rates of relapse, higher satisfaction. So often we're doing high dosages because of iPledge, we want to get done, but you don't necessarily need to do those high dosages. You can certainly get people better, and you might get them better and happier using lower doses than we often use, more like 0.5 milligram per kilogram per day. The last thing about it is we often, again, this ties into that point about chronic dryness. We're often trying to treat to these like targets, like 120 or 150, and now people talk about 220 milligrams per kilogram. And the goal here is we're trying to prevent relapse. But actually, the most predictive thing about relapse, when we look at it, and this is a really nice cohort study from Marius Rademacher in New Zealand, the most predictive thing is being clear for 2 or 3 months. It's not cumulative dose, it's not daily dose, it's being clear. And that actually kind of makes sense with what we've seen in our patients, right? If someone's not clear when you stop them, they're obviously not going to be better. Even if they're at 220 milligrams, they're not better. So thinking about treating to a clinical endpoint instead of the arbitrary dosing targets, I think helps us right size our dosing better to our patients. I think it's going to help us reduce our rate of relapse by undertreating people, and also potentially reduce our rate of overtreating people by trying to always go to high targets and potentially increase the risk of lasting dryness or other side effects associated with isotretinoin. So again, kind of opportunity to individualize our treatment regimens. And the last part I want to talk about monitoring for isotretinoin. So just to think about, why do we check labs? We really want to prevent an adverse event, or we want to guide dosing. And what are the downsides of doing this? Well, pain, fear. I mean, how many people come into our offices, if you're a doctor on Reddit and you're reading things going, oh my God, they check these labs, that must mean this medicine is bad or scary if someone needs to do that. And cost, right? Often with high deductible plans, patients are paying for these. So what's the optimal approach to lab monitoring? This is data from our group looking at about 1,600 patients treated with isotretinoin. And what we find is, as I think everyone knows, patients get higher triglycerides and cholesterol. They tend to plateau right around when you reach Stokes. There's really no changes in AST or ALT, no changes in white blood cells or platelets. But of course, these are averages, right? These are means and medians. What we care about is like that patient is going to have that rare problem, right? That's what we're trying to find. Well, what about clinically meaningful lipid abnormalities? Only about 0.3% of people during the course of isotretinoin have a meaningful lipid abnormality of having lipids or triglycerides over 500. And notably, about 75% of those patients discontinued their isotretinoin, had it rechecked, was normal. Maybe they ate a hamburger before they got it checked. And so many of these are false positives and don't impact treatment. Going back to, again, if we're not affecting management, why are we doing it? More importantly, can this actually help us prevent problems? When we look at cases of pancreatitis, right, that's our worry about high triglycerides. Most of those patients don't have elevated triglycerides. It seems like it might be an idiopathic side effect if it does occur. It might actually just be coincidental. It's so rarely reported. But thus, lipid monitoring is probably really limited value. And actually, a recent British Medical Journal critically appraised topic said there's really no point in checking lipids in patients on isotretinoin because one, this is so rare. How often are we actually going to catch it? And two, we're checking something that doesn't actually predict the thing we're trying to catch. Then LFT changes, similar story actually to when we look at potassium with spironolactone, which is that there are rare changes. Most of them are really mild, but notably, they're just as common at baseline before you even start the medicine as on treatment. And that kind of suggests that it's just a random type of background noise rather than something meaningful. And again, does this actually help us prevent hepatotoxicity? It's not clear because there's really been no clear cases of lasting hepatic injury from isotretinoin, and thus it's probably of limited value. Again, kind of similar reasoning to try to check LFTs in this patient population. And then we don't find any meaningful changes in CBC, platelets, white blood cells, nothing there, similar to other people's work. The other question that comes up is CPK. And this comes up, patients can't get rhabdomyolysis on isotretinoin. The problem with CPK is it's really not specific. If you just check CPK in people like me, you, anybody, about 5 to 40% of us have mild elevations, especially if we're a male, if we're someone who's active. Athletes often just at baseline have elevations. If we went and did it with the Boston Celtics, a lot of them would have elevated CPKs. And runners, 20x elevations after a marathon. Fortunately, with isotretinoin, most people who are going to have meaningful rhabdomyolysis and CPK elevations have symptoms. So from my standpoint, I think it's not that helpful to check it because you're going to find so many false positives. You're going to be treating numbers, not the patient. And the incidence of rhabdomyolysis is really rare. And again, usually have symptoms. So unless they have symptoms, I think the value of checking as kind of a routine screening thing is very low. These are some other studies kind of showing the same thing. And then this is a question about should we check baseline labs? This is a study from Rasmussen where they looked at baseline abnormalities and do they predict abnormalities on treatment again? Like if we're checking labs, it should help us guide therapy. If we're checking baseline labs, it should help us identify at-risk patients. And largely what they show is that the baseline abnormalities tend not to line up with the abnormalities patients have during treatment. And thus, again, are they actually helping us? Do we need those labs? So to try to get some more clarity in this issue, our group recently conducted a Delphi study, and the consensus here was to just check an ALT, really, or if you want to, LFTs and triglycerides, or if you want to, a lipid panel prior to initiation, and then at peak dose. And after that, really no additional laboratory monitoring is required. And we hope that this will help bridge this really evidence to practice gap where, again, similar to spironolactone, we just see people checking labs very frequently. About 40% of patients are getting monthly labs for treated with isotretinoin even today. And I think there's a real opportunity to help our patients to reduce the necessary fear that they have. So that's my approach. No CBCs, there's no evidence for that. I don't check CKs really because I think it's impractical more than anything else. And then I think intermittent ALT and triglyceride monitoring is reasonable. As we kind of went through, it's not clear that these labs really help us anyway. So I do think no monitoring is an acceptable approach. And there are patients who, we talk about the risks and benefits and we decide, we're not going to check any labs. We don't think that's helpful. And even just going from where we are right now to that baseline and peak dose strategy, that could save over $100 million a year in the United States alone. I think about in the world, probably even more. And going to that no lab approach is even more than that. So to summarize overall, this section for isotretinoin, consider omega-3s to reduce mucocutaneous side effects. Antihistamines might help as well. Often we can help also by lowering the dose and considering treating those clinical endpoints rather than arbitrary cumulative doses, both to improve our rates of relapse prevention and to help avoid potential lasting side effect issues from isotretinoin. And we're probably generally over-testing and over-monitoring our patients, both for isotretinoin and spironolactone. And with that, I wanted to leave plenty of time so we can have a nice discussion. So I will pause there. Thanks everyone for your attention and look forward to continuing this discussion with everyone.